Well, welcome. Tonight we have a very special guest. I'm not quite sure how to characterize him because you seem to be in a unique position here. So let's start with an introduction.
Well, first of all, thank you for the invitation, and I really appreciate the opportunity to come and talk about ophthalmology in Milford. It's been a pleasure of mine to be here tonight, and I'm looking forward to it very much. Glenn Goodman is my name. Been in the area here for 31 years practicing ophthalmology.
Now, you're located up the top of West Street, basically by the courthouse.
Yes, yeah.
Can't miss the sign.
Can't miss the sign. No, that was a suggestion years ago when I bought the building to have a nice presence up there. It's a beautiful location, and some of the sign companies in Milford were happy to have my business.
Now, help me understand, because you're not a hospital, but you have operating rooms. You're not ye old ophthalmic surgeon, from old days with a little office and one chair. How would you describe your practice? Because it is unique.
Well, thank you. It is unique. We have a very state-of-the-art center there. A lot of hard work went into it. And we have basically two different portions of ophthalmology being practiced there. When I'm not in the operating room, I'm doing medical eye exams and diagnosing, treating various conditions in young people, old people, and from run-of-the-mill red eye, pink eye, conjunctivitis type of infections to serious glaucoma and blinding disorders. And that can be done in any building that's appropriately designed. There are no special permits per se to do ophthalmology, as there wouldn't be with any specialty, gastroenterology.
But yet, didn't you have to get a special license for your
Well,
practice?
yes, that's the other side of the building. That's the crown jewel in the building there. That's the cataract surgery center, a portion of the building. That is a very specialized facility that took 2 years to develop because of the state and the federal requirements. It's essentially to the state and the federal evaluators and the licensors, it's a hospital. And whether it's Milford Hospital or the Cataract Surgery Center, or for that matter, Mass Eye and Ear, we all have to play by the same rules regarding sterility and every aspect from the time the patient walks onto the property to the time they get signed in, to the time they have their operation and get signed out. There are regulations by the book, and it's a lot of constant monitoring.
So you're held to the same standard and regs as Uncle Frank down the street, Frank Saber's medical center. Absolutely,
yes. The accrediting organizations are largely the same, and the sanctions are no different. The state and or the federal regulators, appropriately so, and I agree with all of this, can shut any of these centers down, whether it be a hospital or my center, if we are not following the rules. Yes.
So like a JCO type standard that the hospital has to live to, they're not going to cut you any slack just because you're not a huge medical center.
No, not one bit. The minimum requirement, just as it is in a hospital, is every 3 years you have to have a 2-day on-site inspection by Medicare, and it's a very intensive process. They actually, it's the several I've had, because I've had 3 of these now. I should add that we've passed them all with flying colors on the first try each time.
Hats off to Mother Rachel for the admin.
Yeah, exactly. And it's typically 1 or 2 nurses who specialize in outpatient surgical facilities, and oftentimes a physician. These are professionals who are retired or semi-retired and who don't get paid. They do this to ensure that the surgical facilities around the country meet minimum acceptable standards. and they go through all of our books, all of our regulations. They observe me in surgery. They pull patients aside, apart from me being in the room, to ask how the experience was for them. And it's very rigorous. And then what happened the last time we had this, a year or so ago, 2 years ago in December, as a follow-up, the state investigators came through. Again, just part of their doing their job. And this is another whole group of, in this case, 2 very experienced nurses who made sure that the facility was up to par. And if I say so myself, we've never had any detriments, and the investigators that come to do these inspections have always had fairly glowing reviews of our efforts. And let me say at the outset, certainly it's not only myself there. There's a whole team behind me that's responsible for any number of things, from sterility to planning, office planning, to patient care. I could talk on, but we have to.
So now these inspectors, like when
yes,
when I was running the diagnostic lab, College of American Pathologists was our accrediting agency, and they sent in laboratory directors. So these were people who really had run clinical labs. They knew what to look for. So it wasn't like you could get a young inspector and they'd overlook something. It sounds like about the same idea.
That is exactly correct. One of the issues, just to highlight that, is we use, it's obviously with eye surgery, there's a lot of cutting of tissue, and there was a tendency around the country 5 years ago for surgeons and facilities to purchase what are called single-use blades, single-use instruments, and re-sterilize them and reuse them, thinking, quote, nobody would notice. And for example, when these inspectors come, they want to see how many surgeries I do in a course of a year, and they want to see invoices for that number of disposable blades. And so there's no cutting corners.
So they were using disposable scalpels and autoclaving them?
Yes.
Now that's a scary movie.
Absolutely.
I mean, when you think about it, as any device manufacturer I've worked with, you validate for use. So there's no way I'm going to put into a disposable what I put into a reusable, because I only expect it to be used once.
Well, you understand that, and the truth of the matter is the physicians and the staff understand it, but like anything else, there's always the tendency to save money and cut corners. And once you start, in my opinion, once you start down that route, you lead by example. And I lead by example, but we never would do something like that, yes.
Well, I mean, it'd be hard for a staff member, if they see the CEO essentially, the chief medical officer of the group, cutting corners. I mean, it used to be the problem, like when we were in Moscow, and you'd see them reusing needles, and they, quote, autoclaved them. And you sit there and say, wait a minute, guys, this is not a 17, a huge gauge needle.
Mm-hmm.
Autoclaving may kill a lot of the protein, but you're still going to have some of that DNA flitting around that can be picked up by retroviruses.
That's exactly, well, of course, yes.
And then if they see you doing it, well, maybe I don't have to clean, or autoclaving's kind of annoying. Maybe I can just rinse it. Like you said, it sounds like a horrible slope that you're going to slide
That's
down.
exactly right. And you said it very well. That's the slippery slope that you think nobody's going to see it. And the real risk there is patient care, because there could, as you say, be germs of any number of sorts that don't get removed, and they're now implanted in somebody's eye. Yeah.
Now, you set up a surgery suite and a traditional eye care suite. I don't know of very many in the area like that.
No, this was a dream of mine over the last decade or so, and I have made as many mistakes as I've had successes. And when this building up at West Street and Highland Street was on the market, it was, as you may recall, if I say, a fairly dilapidated a daycare building. And I didn't see that. I saw a beautiful surgical center there, and a lot of people thought I needed a hit in the head with a baseball bat. But I stuck to my guns and, emptied out the bank account many times, and and it's I have no regrets at the present time. So in 2008, when I was doing this, just coincidentally, I wish I could claim some innate business acumen here, but it was 99% my good fortune, i.e. luck, that the state of Massachusetts in 2008 changed the rules on surgical centers, not just in Milford and not just for ophthalmology. Statewide, you now cannot, basically you cannot set up a surgical center in any specialty in Massachusetts for the foreseeable future.
So you got in right under the wire.
Yes. In fact, I have in 2008, I received the last ophthalmology license for this type of endeavor. There was a hand center down on the Cape that they were the last ones altogether. So it's priceless that I was able to do this. And my feeling was, as I was planning the center, was to do it second to none. If I was going to do it, I wanted it to be what we call now, and this is a tribute to Rachel, concierge cataract care. We don't just do cataracts, and the emphasis is on concierge without the concierge cost. There's a new trend in medicine, concierge care, where you pay the doctor money to be a select patient. We don't do that. We just treat everybody in a very high-end, first-class way, to use an airline analogy, and that's coming directly from me and my motivations. That we make it look relatively easy, but there's a lot of hard work by very many good people behind the scenes that make the experience for the patients largely very satisfying for them, and therefore for me and the
So
staff.
I can get concierge level at economy price.
We only.
I would like that.
Yeah, well, I enjoy surgery and I enjoy the patient, so that's a good marriage for me, and even for those patients that don't have insurance, we don't schlep them to a hospital just so I just do the surgery don't get paid. That comes up, not looking for sympathy or a pat in the back. It's just my way of doing things. So several times a month, somebody will not have surgery that they can have it done in the center, but they get the same care, the same.
Now, fundamental question always comes up. I just moved to Milford. I need eye care. I can go, and I don't mean any slam, but I can go to Kmart, because you see a lot of ads that you can get the same level of care for a rock bottom price, $2, we'll do your cataracts,
Yeah.
I can go to an optometrist, I can go to an ophthalmic surgeon. Okay, I go to the phone book, and I see Goodman ad's big, but I see lots of ads. How does a new person, what would you recommend that they look at, evaluate to pick somebody who's going to provide? I guess cardiac care would be right up there too, but eye care is probably the one thing that hits you straight from morning till night.
Well, you phrase it in a very astute way. Having done this in private practice in Milford for over 30 years, I think I have a good perspective on how I could advise patients to approach those type of questions. And it typically, there's no right or wrong way to do it, and there's no way that always works without some trepidation. If it's
Wait a minute. First of all, let me interrupt.
Yes.
You've been here 3 decades. So this is not, what worries me
Yep.
and I shouldn't call it the Kmart, but the discount store, the big box store, whatever they're called, is I'm going to get somebody who comes in for 6 months and leave. So right away you're telling me, okay, you've been here 3 decades. So you're kind of invested in Milford. So there's a
Yes.
positive I like.
Yes, thank you. Yes. Well,
Now
but
what?
Well, I think if it's a matter of anything that is a serious condition, and let's limit this to an ophthalmic or eye disease condition. Just to give credit where it's due, many of the optometrists in the community are very good these days. The younger generation of optometrists are very well trained, and they're excellent at diagnostically coming to a decision, and then they refer usually to an ophthalmologist. So I've tried to have a good working relationship with the community's optometrists, because a lot of patients, because of their health plans or their history of growing up, the family might have gone to an optometrist for eye care. Nothing wrong with that. And then the rubber hits the road, to sort of mix metaphors, about if it's a serious eye condition and the patient needs to be referred. That's where I can speak to what's important. So if it's, for example, the two big ones or three big ones would be glaucoma, macular degeneration, and cataracts. You want to go to an ophthalmic surgeon or ophthalmologist who you can trust. And I think that's something that you perhaps get from word of mouth. I think it's critically important that the patient feel comfortable with his or her doctor, that the doctor, the ophthalmologist, should be board certified. And what that means is a process by an independent organization, that the American Board of Ophthalmology, that grades us. We have to pass a written exam, then we have to pass an oral exam. That's at least the foundation of the training program. And the doctor should have some experience in the condition that you're coming with. So if I see somebody, hopefully, if I see somebody with a cataract, hopefully I can advise them intelligently. Now, just to talk about cataracts for a moment, I probably send out of the room, out of the office on a daily basis, as many cataract patients that are referred in for surgery as I actually schedule for surgery. Because a lot of times patients don't need the surgery quite yet. And there's no need to rush into those. But that's where the trust factor comes in. Or being able to spend time with a glaucoma patient. These are patients that are on eye drops 2, 3, 4 times a day for their whole life. How are they doing? Are they really using the therapy the way it's designed? Macular degeneration. My own mom is 90 years old. She's legally blind from macular degeneration. So it has hit home with me. So I take these things very seriously. I have from over the last 30 years. And so there are any number of ophthalmologists in the community or throughout New England. And I just want to set my practice as a honorable practice where we all try very hard to give the best of care.
But now when we talk about cataracts, I mean, that one hits home because all of a sudden things started going fuzzy, and during the day I couldn't even read signs. And I was told, well, you could go blind or you can deal with the cataracts. And I thought going blind wasn't a good thing. But at that point, I had to go to an ophthalmic surgeon because nobody else can actually perform the surgery. I mean, you can't go to an optometrist for surgery, correct?
That's correct, yes. Yes.
So you mentioned board certified. So there's one knockout criteria I want to look at when I'm
That's a good
trying
point.
to decide.
Yes.
I mean, to me, unfortunately, the soccer field seems to be the great equalizer. As you look around while you're watching your kids play soccer and say, who do you go to?
Yeah, that's a very good point.
You know,
Yes,
it's
yep.
just so funny when
Yep.
I hear so many patients have chosen their physicians because the other soccer moms or the other soccer dads
Exactly.
said, I went
Yep,
here.
yep.
So board certified, experience. I mean, being from the center of the universe, I like people who are invested in our little town because I figure if you've been here 30 years, you're not going to leave real quick. You know, there's something to say about you've built your practice here, and you can't be too bad if you've survived for 30 years.
Well, thank you, but furthermore, I often, somewhat regretfully, end up doing consultations at Market Basket on Saturday mornings. When a patient, perhaps that had surgery 4 days earlier, comes over to me in the aisle and wants to ask a question. So if I have to duck around the corners because 3 out of 4 patients want to kill me, that's not a good reason
Well,
to
yeah,
stay here.
if they're throwing the tomatoes at you while
Yeah,
you're in
exactly.
Market Basket, not a good thing.
But we have, I lead by example in my office, and we've just in the last, within the past year, we spent about $250,000 on a new microscope and a new called a phacoemulsifier, which is the main cataract machine. That machine is only about a month or 2 old in my office, and the one that it replaced was state of the art. So we really are very well respected in the industry. If I can just brag a little bit, the new phacoemulsifier, otherwise known as a phaco machine that I just purchased, has not been sold yet to Mass Eye and Ear. I will say that's not because they wanted to sell Glenn Goodman first. Before it was just easier to sell Glenn Goodman one as opposed to a dozen or so at the Mass Eye and Ear. But that's the level, to be serious, that's the level that my surgical center is seen at by the ophthalmic representatives with whom I deal on a regular basis. We have a retina doctor in our practice who's been at the Mass Eye and Ear for decades, and without asking, and he has no reason to say this, but he's stated that the operating room that he uses at my facility is neater and cleaner and more hygienic than the one he uses at the Mass Eye and Ear. Now, and we take a great deal of pride in that.
And now, do other surgeons come to your center? I mean, is that
Yes,
open
yep.
to other surgeons?
Yes, that's a good question. I would say nationally, around the country, maybe at the most 40% of cataract surgeries are done in a hospital setting. The transition of the last decade has been to transition cataract surgery out of the general hospital. General hospitals are good for, like you said earlier, heart attacks, stroke, God forbid, serious things. Ophthalmic surgery and ophthalmology surgery procedures are usually not a high level of preference. The staff, as good as they are in general, are not attuned just to eye cases. So around the country, there's a significant transition, and Massachusetts is fairly conservative, to doing cataract surgery outpatient in the surgical center. And so yes, there are other surgeons in the community who are using my facility because it's a separate entrance, a separate facility. There's no politics or I don't even see. Yes.
It's not like they're taking their patients and giving them to you.
Oh, absolutely not. No,
They're using your
That's
center.
exactly
Well, it'd be
correct.
the same thing as going to Milford Hospital.
Oh, yes, exactly.
They're
right.
not turning over their patients to the hospital.
No, we just, and and again, thanks to Rachel, we provide, if the patients come from out of the community, we provide taxi service at our expense. So we try to really do it in a ooh-ah type of way. And to me, it may not be the most financially aggressive way to do things, but it sure is a lot of fun. And we really have a good time. Just to give you another example, if you've come across any of my patients in the area here, for the last 30 years, I shouldn't tell you this because other patients might pick up on this that haven't had surgery yet, but it's no big deal. I always give the patients an African violet or some type of nice plant with a photograph of me and the staff the next morning when they come back. So I've been doing that since day one, and I have no intention of stopping that. It's the little things that make this fun. Now, the surgery itself is very demanding. It's much more demanding in 2014 than it was in 1984. The techniques,
How so? I mean, what has really changed? Because from a patient perspective, okay, I read and I say, wait a minute, you're going to cut a 3mm slit in my eye? You're going to pulverize my lens with an ultrasound probe? I mean, all of these things did not endear me to the idea, but I go in, and the next thing I know, they're telling me it's done.
Mm-hmm.
So from a patient standpoint, I have to tell you, it seemed really easy to have cataracts done.
That's exactly right, and that's the way it should be. That's what we want. That's what we strive for the patient to say, quote, there was nothing to it. What goes on behind the scenes, so to speak, there's a lot to it. There's an infusion bottle with fluid going into the eye. There is this titanium pulverizer, if you will. There's a pedal at each of my feet, and there are monitors going, and I'm looking at so many things, and my assistant is handing me instruments. And so it is very challenging surgery. And the thing that's changed over the last 20 years is the transition to small incision, like you say, 2 or 3 millimeters, foldable lens implants. We now have bifocal lens implants. We have astigmatic lens
Now,
implants.
help me understand. When I did mine years ago, now, again, I have no clue. So a friend of mine was one of the head ophthalmic surgeons down at Walter Reed. Kid I graduated with, he's my age. Old man I graduated, had ophthalmic surgeon for many decades. I called them and I said, okay, I understand there's the plain old lenses, and then they got these fancy circular whatever it was that lets me see both far and close. back in the old days, they told me, well, if you get the progressive or whatever you call it, the graduated ones, you'll have okay vision throughout. Back then, they both told me, pick. So I picked lenses that all of a sudden my granny glasses went away and I could
Yeah.
see perfectly short,
Yes.
and I have to wear my glasses for long.
Okay.
Has that changed now, or?
Well, somewhat it has, and ophthalmology is a very equipment-intensive and technology-intensive specialty. It's some of the things we do now would have been truly science fiction 10 years ago. So you're asking about lens implants. When the cataract comes out, we have to put an artificial lens in. In my days, years ago, we didn't have implants. People wore those thick glasses called Coke bottle glasses.
Yes.
Then there was a period of a decade or so where contact lenses were used after cataract surgery, again, before implants. But people in their 70s, 80s, and 90s had a hard time with contact lenses. So Dr. Fyodorov in Russia, in the 70s, I guess, developed lens implants. And they were poo-pooed, they were criticized, and it was only the rogue ophthalmologist would do it, and we're going to damage the eyes and what have you. And it's been a lot of give and take over the years about the best way to, safety-wise, to approach this. But nonetheless, the use of intraocular lens implants is the standard of care these days. They can be made out of some form of plastic or silicone. They can be rigid. They can be foldable. Now, the most recent advent is what we call the multifocal. And that's in its infancy. It's in its development. I use them fairly often, but you have to be very selective in 2014, not what you may be able to have in your eye, and you would go, like you say, to the soccer game and say, well, Dr. Goodman put a multifocal and I can see far away and I can read the menu without glasses. Then you would say, well, why didn't he tell me I could have that? Well, because not every eye is amenable to that type of technology in 2014. Maybe we can both sit down here in 5 or 10 years and talk again, and we'll look back and say, boy, that was really strange back then. Now, if you don't get a multifocal implant, the surgeon didn't give you the best of care. So this is what makes it very exciting for me, and we try to educate people. That's the fun of it. I have medical students come through. I've trained dozens and dozens of other doctors over the years, and we learn from each other, and it's a wonderful experience.
So now, if I asked you fundamentally, to a sociology major, what is a cataract and why do I get it? Was I drinking too much? Was I smoking too much? What did I do to get cataracts?
It's a good question. I can't give you a quick, simple answer. Of all the options you just threw at me, certainly smoking would be number one to stop for any, as you know,
Well,
any
that's
number
for
of
any
reasons.
reason, yes.
But sometimes we see people in their 60s, heavy smokers with 80-year-old cataracts. But typically, we all tend to get them as an aging process. You can go through a list of issues that cause cataracts. Diabetes, diabetic patients more prone to cataracts. Anybody that's been on long-term steroid, cortisone use, whether it's a drop or pill or shot, cataracts.
Now, cataract is what, a glycogen deposit, or?
It's a hardening of the lens of the eye. The lens is in the middle of our eye, and I tell the patient, just like any